Good evening, friends. I'm very happy to meet you all this evening for this AGS Prime Time, the flagship event of the Indian Association of Gastrointestinal Endoscopic Surgeons. Friends from India, friends from across the globe, good evening, good morning. Thank you for joining us this evening. We have two exciting talks lined up for you to learn from their wisdom and vast experience. Prime Time may have the honor of event of the Indian Association of Gastrointestinal Endoscopic Surgeons. Sunil Papat. Friends, Professor Sunil Papat is the President of the Indian Association of Gastrointestinal Endo-surgeons. He's also the chairman of the Nidhi Hospitals at Ahmedabad. He's an Foregut surgeon by himself, and he also has a special interest on endotherapy. She also specializes in advanced laparoscopic surgery. And in spite of having these corona restrictions, Professor Sunil Papat has been creating new avenues and new platforms for learning, and he's taking IAGES to higher strides. May I invite the President for his few words to start with. Over to you, President.
Thank you, Dr. Kanagwal. Good evening, everybody. Good evening, friends. Welcome to yet another exciting episode of IAGES Prime Time. IAGES, an organization of 8,000 laparoscopic and GI surgeons of India, is into its 20th year of existence. And the organization, which started with the membership of 25 in 1993, has progressed to more than 8,000 members due to the support, encouragement, and teachings of the IAGES mass and senior leadership. I'm pleased to welcome here Professor B. Krishna Rao, who is also considered father of GI endoscopy in IAGES and in India, and has been a guru to all of us. Welcome, sir. I welcome our eminent foreign faculty today from Abu Dhabi, Cleveland Clinic, Abu Dhabi, Dr. Matthew Crow. Today we are having two eminent faculties. First, Dr. Matthew Crow from Cleveland Clinic, Abu Dhabi, who is going to talk on recent advances in Foregut and bariatric GI endoscopy. Dr. Crow has been a prolific Foregut surgeon, has worked so many years in Cleveland Clinic, Ohio, and is now chair of GI and laparoscopic surgery at Cleveland Clinic, Ohio. Welcome, Dr. Crow. Our second speaker is Dr. D. Nageshwar Reddy, who is chairman of AIG in Hyderabad, which is Asian Institute of Gastroenterology. Dr. Nageshwar Reddy is also guru for me for ERCP and advanced endoscopy, and has been awarded Padma Shri and Padma Bhushan and many other accolades from across the world. American Society of Gastrointestinal also awarded with Master Endoscopist, which is considered Nobel Prize in GI endoscopy. So friends, today we are having two eminent GI endoscopists from across the world, and they are going to showcase the recent advances in the GI endoscopy. IAGES is organizing IAGES Prime Time fortnightly, and this program has become very, very mature and very popular across the surgical fraternity of India. Now we are regularly getting more than 1,000 listeners for this program since last several programs. And I'm very happy today that we have two eminent speakers with senior leadership from IAGES. Without much ado, I will invite Dr. Kanagwal to proceed with today's scientific program.
Thank you, President. Thank you for sharing the information and introducing the program. Now I have the honor of introducing Dr. Suviraj John, a good friend of all of us. And then he's a dynamic laparoscopic surgeon and robotic surgeon. He had a brilliant career spanning across various states, having his school education. Later, he graduated out of Christian Medical College, Vellore, and he did his master's from the Christian Medical College, Vellore. And he had his fellowship in the minimal access surgery from the GEM Hospital, Coimbatore. And later, he has worked at multiple places. He also has a very keen in health education and quality management of health issues. And he also travels widely, and he's been a much welcome faculty in all the minimally invasive fellowship programs, and has been contributing a lot on the academic grounds on various platforms. Dr. Suvi has been instrumental in creating this connect with Professor Crow. Can I have the honor of inviting Dr. Suviraj to take over the proceedings, please? Over to you, Dr. Suvi.
Thank you, Dr. Kanagvel. Thank you very much for that kind and generous introduction. Thank you, President Rusunit Baput, for making my job easier and introducing a very eminent speaker this evening, Dr. Matthew Crow from the Cleveland Clinic. It's also a privilege to be in the presence of legends like Dr. Krishna Rao and Dr. Nageshwar Reddy. Thank you very much, IAGES, for this opportunity. This evening, to introduce our first speaker, Professor Matthew Crow is currently the chair of the Digestive Disease Institute at the Cleveland Clinic, Abu Dhabi. He's also currently professor of surgery at Cleveland Clinic Lerner College of Medicine at Ohio in the United States. He'll be shortly taking over as vice chair of innovation and emerging technologies, along with being a professor of surgery at the facility at Cleveland Clinic in the US. He's going to remain active in the clinical field with leadership roles in laparoscopic surgery and surgical endoscopy. His active academic and research interest spans over 2 decades with hundreds of publications. The key thing in context today I will bring to your notice is that he's been the pioneer in introducing endoscopic and aortic single port interventions at the Cleveland Clinic facility in Ohio. Especially of note has to bring the peroral stenotic sleeve myotomy, the peroral endoscopic pylori myotomy, and the endoscopic sleeve gastroplasty at the Cleveland Clinic. I'm not going to take more of your time. I'm going to leave him to introduce these topic heads as well as his immense experience. Over to you, Crow. We keenly look forward to your experience and expertise to be shared with us.
Thank you, Suviraj, and thanks to the IAGES and leadership for the opportunity to speak with you tonight. It's a pleasure to be here, and I hope that we can all see each other again in person in the not too distant future. So my talk tonight is on new vistas in foregut and bariatric endoscopy. These are my disclosures, really none of which are pertinent to this talk. And the goals for the next time together here is to review current surgical endoscopy techniques with specific foregut applications and look at future applications for surgical endoscopy and training. One of the themes that I want to focus on tonight is that surgical endoscopy is at the crossroads of specialties in gastroenterology, advanced interventional gastroenterology, and surgical endoscopy. And the providers that perform this often are from both fields, and it's a wonderful opportunity for us to collaborate on strengths, and that'll be a recurring theme in my talk tonight. But I think that many surgeons in certain parts of the world don't realize the rich history of surgeons in endoscopy, because many of the common interventions that we currently employ in endoscopic procedures were initially described by surgeons. And surgeons today may not do endoscopy at the level of our gastroenterology colleagues, but many gastrointestinal surgeons do. And it's an incredibly useful tool for preoperative evaluation of patients, especially in revisional surgery. It allows for tissue sampling and location of lesions that need to be resected. In the operating room, we can use this to look at anastomotic integrity or to treat bleeding. And then postoperatively, we can manage complications. And I'll touch on some of these topics tonight. But I think what is most probing and hopefully compelling to the audience tonight is that endoluminal surgery is an evolving field that both surgeons and interventional gastroenterologists need to be active parts of. Because really, endoluminal surgery equals surgical endoscopy, performing operations through an endoscope. And if we look at evolving endoluminal techniques, and many of you would consider these to be amongst the cutting edge and most commonly performed procedures, much of this has really become evolved endoluminal techniques, from ablation of Barrett's mucosa, EMR, ESD, POEM. Notes in certain centers with expertise exist, but the first four really are relatively commonplace worldwide. And the types of tools that we have are increasingly complex and are starting to look much more like our laparoscopic instruments, with the ability to dissect, retract, use advanced energy, and divide. These instruments have end effectors that can be changed, a separate scope, often within a scope or adjacent to it, that allows for different planes of manipulation of tissue. And the instruments that we use commercially available to perform endoluminal procedures look a lot like our surgical devices as well, whether it's a triangle tip knife or an insulated tip knife for tissue division, or even a hook knife, which looks very similar to our laparoscopic hooks. End effectors like caps that allow for tissue distraction and dissection. Suturing devices have improved significantly with the ability to take larger and more robust bites of tissue for apposition, and with different types of suture, including permanent and absorbable. And closure devices allow us to bring larger pieces of tissue together as well. So I think before we dive into what is coming, I'd like to just refresh the audience's mind in terms of what is endoluminal surgery today, not tomorrow, and the diseases and disease processes that have largely been supplanted by endoluminal interventions, one of which is RF ablation for Barrett's. This is a landmark article using radiofrequency ablation in Barrett's esophagus in the New England Journal of Medicine from 2009. Looking at patients with IM, complete eradication, 77%, low-grade dysplasia, 90%, and high-grade dysplasia, 80%, in an intention to treat analysis. This has allowed us to shift the focus of Barrett's largely to an endoluminal procedure. And then when there are other lesions that need to be resected, whether it's in the esophagus or the stomach or the lower GI tract, EMR is a long-standing technique that allows us to remove lesions of certain sizes for pathologic evaluation. But increasingly now we're able to do endoscopic submucosal dissection. And this is different than EMR because we can take larger pieces of tissue, either for curative intent or to get a large enough specimen to accurately stage a patient. And this is initially described for curative intent with those lesions that have negligible risk of lymph node involvement and that are confined to the mucosa, not the submucosa. But if we look at EMR versus ESD, it's largely about size. So EMR and ESD are both largely successful in terms of resecting lesions less than 10 millimeters. That drops off significantly once it goes above 10 and up to 20. And above 20 millimeters, the success rate of ESD is still quite high in expert hands, but it's nearly impossible to get an en bloc R0 resection with EMR for larger lesions. So how do we take these techniques to other applications? So this is an opportunity for surgical intervention, not surgeon intervention, but surgical innovation. And this can be from a GI or surgical standpoint. And I think one of the most impressive transitions currently is the application of intramural surgery performed by endoscopy for POEM, for achalasia and other esophageal motility disorders. So the first reports initially were in the 1980s, but these were blind incisions, and experimental modern POEM was performed in 2007, but Dr. Haru Inoue published the first human report in 2010. And for the surgeons here, we know that Dr. Heller described an elegant and successful operation that many advanced laparoscopic foregut surgeons thoroughly enjoyed to perform. Initially, a transthoracic anterior and posterior cardiomyotomy, and then a transthoracic single anterior myotomy in the early 1900s, and then revolutionized by the thoracoscopic, then laparoscopic revolutions in the early 1990s by Kosheri. And we know that the success rate of laparoscopic intervention is excellent when performed by surgeons who have experience doing this. So why innovate? Well, we know that there's a spectrum of patients that present with achalasia. Medication can be used, but this is usually for patients that are not good candidates for intervention. Pneumatic dilation has been shown to have excellent short-term effects, but there's a relatively high rate of symptom recurrence and a not insignificant perforation rate. Botox can be effective in the short term, it's safe and easy, but has to be repeated and is certainly not definitive. But really, Heller myotomy is probably what we consider to be the standard by which others should be evaluated. Even though it's done laparoscopically, there are potential surgical complications. We have long-term data and efficacy with this intervention. And now the new, well, not even new, but newer intervention is POEM. It seems, at least in the short term and now some longer term data, is similar efficacy to Heller. It's less invasive because it's performed transorally. It is a complicated technical procedure to perform, and longer term data is lacking. This is an intramural surgical procedure, so not endoluminal and not transmural, but within the wall of the GI tract to form a submucosal tunnel, and then a myotomy of varying lengths down through the LES and then onto the cardia of the stomach. With the endoscopic imaging, you can selectively divide circular muscle fibers. This is the LES that's been divided after POEM, with the longitudinal muscle fibers intact, completely divided LES. Data shows that it's highly effective in the short term, with multiple studies showing effectiveness of Eckhart scores of less than or equal to 3 and greater than 90% of patients. And increasingly now that the world's experience with POEM has increased, we now have up to 5-year data with multiple studies showing durability over that time. In a recent systematic review and meta-analysis of 53 studies on laparoscopic Heller myotomy and 21 studies on POEM, at 12 and 24 months, POEM appears to have better dysphagia improvement, but we do have some concerns about GERD long-term. A recent New England Journal of Medicine article addressed this, but we'll have to see what long-term reflux looks like in patients with POEM. But clearly the data looks compelling up to this point. But let's switch gears a little bit. So we have POEM, and we have this principle of intramural surgery, but let's move a little bit further down the GI tract from the LES to the pylorus, from POEM to GPOEM or to POP, which we refer to as peroral pyloromyotomy, which is an evolving series of peroral acronyms in GI surgery. So gastroparesis is a vexing disease, both for gastroenterologists, internal medicine physicians, and surgeons. And there's a spectrum of interventions. We know that there's a high rate of medical failure. Gastrectomy is indicated sometimes. There are gastric electrical stimulators, and sometimes patients need decompressive gastrostomy and feeding jejunostomy. But where does pyloroplasty or division of the pylorus fit? So this is an interesting progression of data from the group in Oregon, Lee Swanstrom's group and Kevin Revis. They initially described that laparoscopic pyloroplasty is safe and effective first-line surgical therapy for refractory gastroparesis. I think most Foregut surgeons would agree that's a reasonable option. But if you can do that laparoscopically, then you can probably also do it with an intramural approach with peroral endoscopic pyloromyotomy from the same group back in 2015. Similar to POEM procedure, a spot typically on the lesser curve of the stomach is identified, a bleb is raised, and through a tunnel, the pylorus is divided and then sealed. And I'll show you a video of what this looks like real time. This is one of the first procedures that we performed at Cleveland Clinic in Ohio. This lung transplant patient who had a peg with a jejunal extension and was having recurrent aspiration pneumonias for gastroparesis after lung transplant, which is not uncommon. So about 4 centimeters proximal to the pylorus along the lesser curve, we make an injection through the relatively thicker mucosa with blue dye to differentiate between the muscle and the submucosa, and then ultimately the mucosa. The mucosa of the stomach is thicker than the esophagus, so it's a deeper incision with a TT knife here. This is actually a transverse incision, which we find is easier to make that mucosal flap. This is usually about 15 to 20 millimeters in size to allow access to that submucosal plane here. You can see that the mucosa is being deflected downwards. And then we use a TT knife and spray cautery to then carefully separate that loose areolar tissue away from the underlying mucosa and then the muscle above. The tunnel is expanded. We typically repeat injections. This is a biliary extraction balloon that we're using to inject here. We do a little bit of hydrodissection and what you see is kind of in that 10 to 2 position, the pylorus of the stomach, and that submucosal plane below with some CO2 injection. Once the pylorus is identified, similar to poem, a myotomy is performed through pylorus and then onto the duodenum. We very carefully look at the muscle fibers. Obviously, the serosa of the duodenum is quite thin, and we want to make sure we don't have a full thickness injury. This is a division of the pylorus, and then this is divided retrograde back onto the stomach for about a distance of 1 centimeter or so to make sure that we have complete destruction of the pylorus. The scope is then withdrawn from that tract after examination of the tunnel to make sure that it's hemostatic. We use a horizontal series of clips to close the relatively thick mucosa of the stomach here in a transverse fashion, and then passes the scope into the duodenum through the pylorus, shows that it's larger and easy to pass that scope with the cap in place. So we published our initial series of 50 patients in surgical endoscopy, and then later in the Journal of GI Surgery. And our first 100 patients was published in the Annals of Surgery, looking at a spectrum of patients. So 56% were idiopathic. These tend to be more women and younger. 21% were diabetic, and 19% were post-surgical. So remember, some of the other surgical interventions don't work so well on post-surgical patients, but POP or GPOM can be performed on post-surgical patients. All these patients had a GCSI questionnaire and both a solid and liquid gastric emptying study at 90 days. So we had a symptom score as well as objective radiographic evidence. The technical success was 100%. With an average of 33 minutes of performing the procedure. GCSI improved from a pre-procedure to 3.8 to post-procedure to 2.5. This was statistically significant. And importantly, the objective evidence of improved emptying occurred in 78% with a mean improvement in retention by reduction of 3%. So I think these are great examples of how, from a foregut standpoint, endoluminal treatments exist and are being applied, and the creative ways how this is going to be applied to other GI processes. But when we look at bariatric surgery, endoluminal interventions have existed for quite some time, initially from treating complications, now to revision, and also to primary therapies. And I'm just going to run through this briefly to give you an idea of the current state and hopefully some brainstorming about where you think applications can occur in the future. So one of the earliest and most effective interventions is TTS through the scope, balloon dilation for strictures. This is effective with good response rates for most strictures, even for long segment strictures like you see on the right here. Endoluminal treatment of leaks after gastric bypass. This is a Roux-en-Y gastric bypass that has a leak. You can see the contrast extravasation and a couple of drains in that position. Are still and historically have been treated very well with esophageal stents. You have to remember that esophageal stents are off-label use for treatment of anastomotic complications. They are FDA approved for palliation of malignancy, but there's a plethora of data on efficacy, and I'll show you a little bit of that. But we now have better devices. Surgical endoscopy is ripe for innovation, and even esophageal stents are now asymmetrical. They can be delivered over a wire, which is how we did it historically, but now also through the scope with deployable devices through an endoscope. At Cleveland Clinic in Ohio, we published a series of endoscopic stents in the management of anastomotic complications after foregut surgery. Largely these were bariatric surgeries, but they also included other foregut operations. And if we looked at the indications, the leak indications, especially for sleeve gastrectomy and Roux-en-Y, the overall efficacy was quite high. But we know that with these more chronic conditions like sleeve stenosis or long-standing fistula are unlikely to resolve with esophageal stent placement alone. In our series, we had a 77% improvement, and this was in highest in terms of resolution among leak in the acute phase. But beyond that, stents allow patients to improve their overall nutritional status by increasing oral intake within the first 24 hours. But importantly, almost a third of our patients did acquire eventual reintervention by operation. And if we look at the indication for esophageal stents, the International Sleeve Gastrectomy Expert Panel consensus has had several iterations, but and this is one of the earlier ones. Categorization of leaks is critically important because the more chronic they are, the less likely they are to resolve with esophageal stent placement. We know that esophageal stents cause pain, reflux, and often patient intolerance. So we want to make sure that we're selecting the right patients to use these for. And these probably work best in a situation of acute, early, and potentially late, and have to be managed on probably a 2 to 3 week interval to prevent tissue ingrowth and challenges for removal. So it's important to keep track of these patients and to identify which patients will benefit, most likely those that have acute or early complication. So I want to show you a series of endoluminal images of a leak, but also other indications where esophageal stents can be helpful. This is a patient that had sleeve gastrectomy here in Abu Dhabi at another institution, presented to our emergency department a few days afterwards with low-grade fever, mild leukocytosis, and left shoulder pain. Contrast extravasation was seen on a fluoroscopy, and an upper endoscopy was performed by myself, which showed this small leak just distal to the esophageal gastric junction, 2-3 meters. This is the same leak, small defect, relatively healthy otherwise. So I placed a stent, and this was a longer stent that was going to occlude this, landed in the distal esophagus, and then proximal to the pylorus along the length of the stent. But I think this case highlights the critical knowledge of what the surgical anatomy is for the endoscopist. So what you'll see here are a couple of paper clips, and obviously you can see the endoscope. The distal paper clip shows the pylorus. The second paper clip shows the incisura. And you can see a contrast injection with the typical appearance of a leak, 1 to 2 centimeters distal to the esophageal gastric junction, and then tracking up to the left hemidiaphragm. So as we typically do, a guide wire was then placed. That third clip now marks the esophageal gastric junction. You can see the stent being passed down through over the wire. And as the stent is deployed under fluoroscopic and endoscopic imaging, you can see that tightness at the incisura. It's not necessarily a stenosis, but as you can see in the lower part of this image here, not only was it initially narrowed in the incisura, there's actually a fold there. So the most common complication leading to leak after sleeve gastrectomy is no longer technical failure of stapling. It's no longer encroaching on the esophagus. It's actually no longer stenosis of the incisura, but torsion or twisting of the staple line. And at least in the early term, sometimes sleeve can help alleviate some of the nausea and dysphagia. It may promote remodeling, preventing reoperation, hopefully in the future. But esophageal stents are not well tolerated. There's significant reflux. Patients have substernal chest pain, and there's a high rate of explantation due to intolerance. In that series that I showed you earlier from Cleveland Clinic in Ohio, our explantation rate was relatively low, about 5% or so, but other series show it to be much higher. And they're not as effective long-term for chronic leaks. One of the surgical principles that we're applying now to leak of the GI tract after bariatric surgery, but after any Foregut operation, is endoscopic internal drainage. And a tool that we typically use for this are commercially available biliary stents that are standard for ERCP. These are double pigtail stents with a loop in the lumen and one on the abscess side. So instead of covering or bypassing a leak, as esophageal stents do, self-expanding metal stents, these traverse the defect and allow for internal drainage. What does that look like? This is more of a chronic leak after sleeve gastrectomy. I think this patient was about 3 months out. You can still see that a surgical drain is in place there, and you can also see that it's a relatively well-healed chronic cavity on the other side. This is about a 1 centimeter defect. So how do we do this? We place a very flexible, this is a JAG wire, a 0.035 JAG wire that we typically use for ERCP. We do a quick contrast injection to get an idea of how large the abscess cavity is. And then we deploy a series of these stents. So these are either 7 or 10 French, typically 5 centimeter long, double pigtail biliary stents, one loop in the abscess cavity. You can see the loop being deployed there, and then one loop on the luminal side. And just like we do in the bile duct, often we'll put multiple stents in here as well, because the abscess cavity will collapse around the stents, but the purulent fluid and necrotic debris will drain not only through the stents, but around the stents. So you want to fill that defect up with as many stents as will fit through there. And the data on this is pretty compelling. This is a study looking at nearly 70 patients with leak after sleeve gastrectomy, 1 to 3 double pigtail biliary stents replaced. As I said before, these are 7 or 10 French biliary stents, changed on a 4 to 6 week interval. Average time to therapy was 52 days. The overall failure rate was quite low, 8%. These are now chronic leaks, with a mean treatment time of 57 days. And patients underwent 3 endoscopic treatments overall. But you have to remember, these are much better tolerated than esophageal stents. So this is often done as an outpatient setting, as long as the patient doesn't have signs of systemic sepsis. And stent migration occurred in 10%, but when a plastic double pigtail biliary stent migrates, it just passes harmlessly through the GI tract. Whereas migration with a self-expanding metal stent in the esophagus typically requires endoscopic or sometimes even surgical intervention to retrieve those. So obviously there are advantages to endoscopy. It avoids surgical reintervention for complications, and they have relatively low morbidity overall. But one of the challenges for beyond managing complications is efficacy and long-term durability. So I'm going to switch gears a little bit and talk about revisional and primary endoluminal procedures for metabolic disease. We know that failure after bariatric surgery does occur, and there's a spectrum as to why that occurs. Some are patient factors, some are mechanical factors, some are operations. But there's a not insignificant number of patients that do need revision at some point. And if we look at mechanical attributes that can be addressed endoluminally, targets such as an enlarged stoma, gastrogastric fistula, which was more common in an era of non-divided gastric bypass, but still could occur after subclinical leaks and erosion into the remnants. And sometimes for dilated pouches, these can be targets as well. And as I talked about before, we now have better suturing devices, which allow us to be more surgical in terms of our principles, as opposed to this suction and piston device, which we used to have. We now have curved needles with different types of suture for more robust tissue apposition. And in a study published in Surgical Endoscopy now 10 years ago from Cleveland, we looked at patients that had weight regain after roux-en-y gastric bypass. And those patients underwent routine upper endoscopy. About 70% of those had an abnormal upper endoscopy. And the majority of those patients had stomach enlargement, 60%, more so than pouch enlargement or both. So what are the outcomes of endoluminal revision after gastric bypass? Chris Thompson's group in Boston made some of the initial data on this, and this is one of his first studies looking at 25 patients who underwent endoluminal revision with a post-roux-en-y gastric bypass BMI 43 with an average weight regain of 24 kilograms, and their inclusion criteria was an anastomosis greater than 15 millimeters. These were technically successful in all those patients with an overall reduction by 77%. Relatively minor complications overall, and at 3, 6, and 12 months, I think reasonable weight loss of 10 kilograms given the relative low complication profile. And his group is followed up in another publication now looking not just at 3, 6, and 12 months, but at 24 months and at 36 months, which shows that at least some level this is sustained weight loss over up to 3 years. So you might say that that's not long-term data yet, but it's accruing, and at least up to this point so far seems to be relatively compelling. Another novel application of endoluminal gastrojejunal revision is for dumping syndrome. And this is a study that looked at GJ revision for anastomotic outlet reduction from dumping with good success in terms of, they measured this with a SIGSTAD score, which was statistically significant. And the authors also commented that this could be repeated if successful in the first half, if there's a later initial failure. Primary endoluminal procedures for treatment of metabolic disease. Bariatric surgery is durable and effective, and a lot of operations are being performed worldwide. And most people do very well with this. But there are many patients that are looking for non-surgical interventions. Endoluminal applications can be used for standalone procedures for patients who may never undergo bariatric surgery. or as a bridge. And I think that there's a group of patients, probably in the lower BMI range, that either don't want surgery or are not candidates for surgery. They're patients that are high risk, and maybe an endoluminal procedure is a bridge to definitive surgery. And then there are other patients that don't want any bariatric surgery but are ineligible for organ transplantation, orthopedic surgery, or even ventral hernia repair. Intragastric balloons are still popular in certain parts of the world for class 1 and class 2 obesity. They're temporary. If reversible is advantageous, they are. Obviously, they need to be deployed as part of a multidisciplinary approach. And there's multiple types of balloons that are available. There are some that have 12-month duration, double balloons, up to 3 balloons, and now balloons that don't require any endoscopy. And if you look at the results from the pivotal randomized control trials in the US of different manufacturers, overall there's about a 6 to 15% total body weight loss compared to 1 to 5% lifestyle alone. Relatively low severe adverse events, but my suspicion is these are relatively underreported. But we do know that weight regain is common after removal. The newest, well, not the newest, but the most looked after procedure as a primary procedure now is probably endoscopic sleeve gastroplasty, which is an endoluminal approach to tubularization of the stomach, similar to, but not exactly the same as a laparoscopic plication, based on plication of the greater curvature to create a tubularized stomach. There's some data looking at this. This is probably one of the better studies, looking at 3 centers with 24-month follow-up, low BMI, 37, 6 and 24-month outcomes with a primary endpoint of greater than 10% total body weight loss. On a per protocol approach, they reached this on 84%, but less with an intention to treat analysis, less than around 50%. And the authors also concluded this may work better with adjunctive therapies, which is probably true for most of these interventions. Duodenal mucosal resurfacing, this is ablation of the duodenum. There's accruing data on this. This is some of the early data, not on weight loss outcomes, but this group is looking at type 2 diabetes outcomes, hemoglobin A1C, as well as treatment of fatty liver disease, not necessarily for weight loss. Endoluminal barrier liners, which exclude some part of the proximal GI tract. The 2 most common devices are either exclusion of the duodenum or placement in the esophagus and duodenum, and then exclusion of the stomach and duodenum. There have been challenges with this, and the press release here is that the initial endo trial was placed on hold because of a significant adverse events of hepatic abscesses, probably from translocation of the duodenum. We were part of this trial in the United States, and most of the liners are not being used worldwide now. But I hope this talk has given you some perspective on the evolution of minimally invasive surgery. And endoluminal procedures that are similar to surgery are absolutely surgery just performed by endoscopy. But I would challenge anyone to say that the progression we saw from open to laparoscopy really was a one-way progression. But endoluminal treatments in many ways will supplement laparoscopy and treat different patients in different ways. One of the challenges worldwide is that many surgeons who want to do endoscopy, or many gastroenterologists who want to do advanced procedures, don't have avenues for training. The BSAFE program, which is the Bariatric Endoscopy Skills Acquisition Fundamentals Exam, is a co-sponsored curriculum with the American Society of Metabolic Bariatric Surgery and the Society of American Gastrointestinal Endoscopic Surgeons, SAGES. It consists of 3 components: a web-based curriculum, video curriculum, and then a multiple choice online exam that requires a minimum passing based on the web-based video curriculum. And then once that's complete, there is a hands-on technical evaluation by proctors. It's not going to be offered this year because of Corona at SAGES, but hopefully we'll get it on the schedule for next year. This is the website for those of you who might be interested, and I'll put my email address up at the end too. So in conclusion, endoluminal technologies have already supplanted many surgical procedures. Evolving technologies allowing for more complexity and will probably be applied increasingly to other GI tract diseases. and critically important, both surgical and gastroenterological leadership will advance the field of endoluminal surgery. So thank you very much for the opportunity to present tonight. It was a pleasure to be here, and I'm happy to take any questions. Thanks.
Thank you very much, Dr. Crow, for that brilliant presentation. I can see why you're going to go and take a leadership position in innovation and emerging technologies. So many congratulations on that too. Let me start off by taking off on one of your slides. The earlier ones on POEM, you mentioned very clearly that this is the systematic review mentioned that the efficacy in POEM seems to be better than laparoscopic Heller's cardiomyotomy. That's the first part of my question. You can explain, maybe detail that, maybe why, and how would you deal with the follow-up of post-POEM GRD?
Yeah, great questions. Well, I think that POEM, first of all, there's challenges with that study. It's a systematic review meta-analysis. So there's a lot of heterogeneity in the studies that are there. Probably the best study is the New England Journal article that is a randomized study. And we can draw conclusions from that too. I think that from a theory aspect, not just for achalasia, but for other motility disorders of the esophagus, POEM gives you access to the entire esophagus. So for instance, type 3 achalasia, you may want to perform a longer esophageal myotomy. And to perform a long myotomy up into the chest from the abdomen can be quite challenging. But with an endoluminal approach, you can start your myotomy anywhere. So maybe we can do a better job by accessing more of the mediastinal esophagus. Depending on your skill set and comfort level, being able to selectively divide the circular muscle fibers instead of longitudinal may have some benefits. Long-term data remains to see whether that's true or not. But when we do a laparoscopic Heller myotomy, two things happen, regardless of your technique. You have to divide the phrenosophageal fat pad and the sling fibers. So we know that the natural anti-reflux barriers are disrupted with that, and that doesn't happen in POEM. And to get to the circular muscle fibers, we have to divide the longitudinal muscle fibers first. So, there may be a selective advantage there. Now you have to weigh that against, sometimes it's hard to know what your distal margin is on the stomach to make sure you divide those cardia fibers. It takes some time to figure that out. And it's a technically challenging procedure to perform. And achalasia is a relatively rare disease. And to be good at this operation, you should be doing a relatively large number of these in any given year. One, to get through your learning curve, and then to make sure that you're doing them effectively. And then the second question you had is, what is the long-term follow-up? Well, one of the biggest challenges of any myotomy is that when the LES is divided, patients are going to be at risk for reflux. Now, we know that even with an anti-reflux procedure, most commonly a DOR, sometimes a toupee, there's still reflux, both clinically significant and then physiologically detected, but not clinically significant. It looks like, and the New England Journal article showed this, that the amount of reflux on physiologic testing may not be that different several years out. And importantly, we know that the rates of severe esophagitis, LA grade B, C, and D, probably don't seem to be that severe, at least in the early post-op period. So my protocol after POEM is to get a repeat time barium swallow, our achalasia protocol at 3 and 12 months. And then we do an upper endoscopy at 1 and 3 years. We don't do pH probes. There are challenges to that for insurance and reimbursement, but I do think it behooves us to make sure that these patients aren't having significant esophagitis afterwards.
Thank you very much. Before I go on to the next set of questions, any questions from the eminent panel here, Dr. Sunil or Dr. Kanagavale? Professor Krishna Rao would like to ask a question. Dr. Rao, sir, please, you need to unmute yourselves.
Thank you, Professor Koff, for an excellent presentation. Enjoy to take a bit of it. There were a point on gastric paresis and you doing a pyloric myotomy. We do the pressure studies in the esophagus. Are there any pressure studies done on the pyloric sphincter to justify the myotomy?
Yeah, great question. There are, but I think the data isn't as helpful as pressure studies in the esophagus. So Manometric studies or real-time measurements of pressure have been used in POEM to gauge the effectiveness of the myotomy and whether additional myotomy needs to be done. The challenge with the pylorus is that the pressures are so variable, it's hard to know what the baseline is, and then once you divide it, whether that's improved or not. So I think there's active research to be done there, but it's not as standardized as it is in the esophagus.
The second point that struck me was you have dealt with so many endoscopic features. Have you had any experience with the magnets for anastomos?
I have not. So the commercially available device is something called Magnamoses, and just for maybe people who are less familiar with that, it's an endoluminal deployed self-affixing magnet that simultaneously from an upper endoscopy and a lower endoscopy pairs. And then once they pair, they cause local ischemia, fusion of the bowel, and then a distal anastomosis. Well, obviously the normal GI tract is still open, but now there's a decreased circuit distally. I do know, at least anecdotally, this is a challenging procedure to perform. It seems compelling, but remains a few steps away from prime time or kind of routine use.
Thank you.
You're welcome.
Professor Crow, Professor Sunil, please go ahead.
Yeah, Dr. Crow, excellent lecture, and you covered all these new procedures very nicely. As you are a surgeon and you are doing POEM as well as Heller's myotomy, when a patient of ectasia comes to you, your choice of procedure and why?
Great question. I think everybody gets a POEM except potentially for very young patients with type 2 achalasia. I think that those patients, the concern for long-term reflux in somebody who's 18, 19, 20 years old over many decades, I'm a bit hesitant, and I have a longer informed consent discussion for them. But otherwise, my practice is probably 90% plus POEM, 10% Heller myotomy.
Dr. Kanagwe.
Yes, Kanagwe.
Professor Crow, trusting the data which has been emerging out of the GPOEM and other things, do we have any study, especially in the sleeve leaks, to tell there is an increased pyloric pressure inherent to the patient? Have we tried to look into some data? Do we have some studies? It is quite interesting to see leaks are managed in a very unique way. But does it mean that we are missing a vital link which can potentially avoid leaks after a sleeve gastrectomy?
It's an interesting physiologic question, and this has been debated. There's very little data on this. The best analogy that I can give you is that there is data looking at Botox injection prior to GPOEM or POP, not for sleeve leaks, but in another area, or for treatment of gastroparesis. That data has not been compelling or showed any difference, and it's relatively well constructed. Now, maybe it's a little different in a sleeve gastrectomy where you have a tubularized stomach, it's a high pressure system, and so maybe smaller fluctuations could be more important. My personal thought is that the distal obstruction is less likely from a pylorus, which we know is very dynamic. It's rarely stenosed, idiopathic, hypertrophic pyloric stenosis, typically a disease of childhood. Rarely in adults, but sometimes we see a tight pylorus, but I think it fluctuates so much. I think more commonly the distal obstruction is from torsion or stenosis, not necessarily from a tight pylorus. But the literature doesn't guide us in that exact scenario.
Well, point is well taken, sir. Thank you very much.
Do we have time for a question, Dr. Kanawale, or?
Yes, sir. Please, one final question.
Dr. Crow, thank you for highlighting the fact of the distal sleeve, the point at the incisura, and the potential risk for torsion and its impact on the proximal aspect of the sleeve. How are you addressing this issue at primary surgery as well as dealing with it? Does it change the profile of GRD presenting to you besides the morbidity of a postoperative situation?
Yeah, I think there's two things that contribute to it. One, I think that there's been a movement to try to move closer and closer to the pylorus. And I think that there's two problems with that. Physiologically, it gets rid of the antral pump, and you probably are more at risk for reflux. And we know that a sleeve gastrectomy can cause reflux because of the high pressure lumen. So I think 4 centimeters is probably where you want to be. And as you get closer to the pylorus, that first staple firing tends to be more horizontal. When you start to get very horizontal, then make that turn around the incisura, if you're not very careful about keeping the anterior and posterior stomach in the same plane, you get this torsion. Now, torsion is very different than stenosis. I think for the most part, stenosis has decreased. Most of us use sizers to make sure that we don't staple too close to the lesser curve. But the torsion may not be seen clearly on an upper endoscopy because you can get a scope through. It's not a narrowing of the lumen. And if the endoscopist isn't familiar with bariatric anatomy, may think, well, there's nothing there. But it can be a functional outlet obstruction. Now, the problem with it is that unlike stenosis, which can be treated pretty effectively with a pneumatic dilation to tear the muscle but keep the mucosa intact, torsion is less likely to respond to that because, again, it's not a stenosis. It's a functional obstruction. So, unfortunately, a lot of those patients will need conversion, typically to a Roux-en-Y gastric bypass. They have symptoms of dysphagia and reflux, and that's from a mid-body obstruction.
Thank you very much. And you really picked this up on your follow-up endoscopy done by the surgeon. Is that right? Or you go with the upper GI series?
I think both are helpful. An upper GI series can sometimes show the contrast, usually twisting posteriorly as it comes down. That's a sign that there's torsion, even though the column of contrast is the same diameter the whole way down. And then an upper endoscopy. And the upper endoscopy lets you see if there's significant esophagitis as well, or other anatomic abnormalities like a large fundus or a hiatal hernia.
Could I actually be brave enough to say that here lies the benefit of the surgeon doing the endoscopy himself, post-op or maybe intra-op, so he can follow that line along the greater curvature and see how much of a twist there is?
Absolutely. I do an endoscopy on every patient in the OR, even a sleeve gastrectomy. I'm not even looking for leaks. I just want to make sure that that staple line endoscopically looks like it does laparoscopically, that there's no torsion, that things are wide open, and to identify any abnormalities, including bleeding staple lines. And then I think that if you're going to operate on a patient for a sleeve revision for reflux, you personally want to know what it looks like. And that's a great opportunity for you to do an endoscopy to plan your surgery.
Thank you. Thank you very much. I think we're out of time for this segment. Dr. Kanagwale, I yield the floor to you. Thank you very much, Dr. Crow, and we look forward to you staying with us for the second half. And maybe if there's time, we could take questions at the end.
Sure.
Thank you very much.
Thanks, everyone.
Thanks, Super. Thank you, Professor Crow. Sunil sir, would like to chip in for a comment before we move on to the Nagesh versus talk?
Yeah, thank you very much, Dr. Crow. It was a wonderful lecture and procedures you showcased. I believe that with the advent of bariatric surgery, many of the bariatric surgeons started learning and doing upper GI endoscopy themselves. And last 5 years, we are seeing that majority of the bariatric surgeons are doing at least post-op endoscopies themselves so that they understand the problem from inside. What are your thoughts on that, Dr. Crow?
No, I think it's critically important. I think for any GI surgeon to add endoscopy is important. And I think just as you described it, it is a great way to start. You keep building on that. So you may do a screening endoscopy for a patient who has reflux before you do bariatric surgery, or maybe a patient has dysphagia and you do a diagnostic endoscopy afterwards, or you scope everyone in the OR. Then you start to build on your skill set. Then maybe you can treat bleeding or an anastomotic stricture. In each of these are specific skills that you can expand upon. And I think as a bariatric surgeon, you know what that anatomy looks like from the outside. You should know what it looks like from the inside too.
Absolutely. Thank you very much, Dr. Crow. We'll move on to our second speaker today and topic today on ERCP in 2021 and beyond. I will invite Dr. Kanagwale to start the second lecture.
Thank you, President. Professor Crow, we'd love to have you amidst for the second talk, or if you have any pressing commitment, please feel free to go ahead with your commitment, Professor Pro. It's been a pleasure having you on board for this important event. Thank you, Subiraj, for hosting Professor Pro and acting a bridge of connect between the IAGES and Professor Pro. And I'm sure IAGES will look forward for more academic deliberations from Professor Pro in the near future. Thank you and good night, Professor Pro.
Thank you very much.
Now, I have the privilege of welcoming Professor Krishna Rao, sir, my teacher. And I've been starting my endoscopic career in the very same room where Professor Krishna Rao sir did his first endoscopy in South India. And sir has been having a very illustrious career. He's been the Johnstone medalist. For people who do not know what is a Johnstone medal in undergraduate period in Madras Medical College, it is a coveted medal who get the maximum number of medals in the Madras Medical College undergraduate career. In fact, there are many years these Johnstone medals go unawarded because it does not reach the target. And he's one of the most prestigious winner. And the same thing, he is the Dr. Chipperfield's gold medal winner during his MS education. So 2 crowns on one head. And later, looking back, he's been trained by the giants like Professor Sohendra and the similar group of professors at the Wisconsin University, Tokyo Medical School, and where not. And to his credit, he has touched the lives of at least 10,000 surgeons on the field of minimally invasive surgery or endoscopy or endotherapy. And he's been instrumental in various modules, creation of new avenues for learning, and he has been continuing to be a pillar of learning source for all the young surgeons and young endotherapists. And in fact, I would say he has become mentor of mentors. So that is the amount of generational knowledge and wealth of experience Professor Krishna Rao has. And we are indeed blessed to have him amidst us for this evening's program. Professor Krishna Rao, sir, I think you have a pleasant duty of introducing Professor Nagi, sir. Over to you, Professor Krishna Rao, sir.
Thank you, Kanagvel, for your very, very kind words. To introduce Nageshwar Reddy to an endoscopic family is taking cold to Birmingham, right? The Nageshwar Reddy has graduated from the Postgraduate Institute in Chandigarh, had his DM there, and thereafter he has excelled himself in therapeutic endoscopy. He has established an internationally recognized center in Hyderabad. He has many things to his credit. It will take a long time for me to go through them individually. But he was the first person to do the notes, transgastric, peroral transgastric appendicectomy and all bladder removal. He has had many innovations in the endoscopic procedures. He is the only person from India who has been able to take part in active endoscopic procedures, both in the United States as well as in Europe. And I think he has trained a large number of gastroenterologists and surgeons in various aspects of endoscopy at the AIG. I think I look forward to hearing his lecture on ERCP, present and future, because we always have many things up his sleeve for us to learn and appreciate. Nagi, I hope you're there to take over your lecture.
While Dr. Nageshwar Reddy is joining, good evening, sir, Professor Krishna Rao.
Good evening,
Nice to
Sunil.
Yeah, nice to see you. Very active in academics, and you have always been an inspiration to all of us.
Yeah, I'm there to help people who want to learn. And this is one of the methodology by which we can transfer our knowledge and our techniques to the younger generation, and also to help them in various aspects of GI. I started off as open surgeon of the GI, laparotomy and proceed. That was the methodology that was there in 1965-66, because we had no endoscopies or anything except we had to go by the barium meal pictures. Then the laparoscopy came, then we came the endoscopy, therapeutic procedures. Then I got interested in the application of lasers in GI, both in open surgery as well as in endoscopy. Some of the things that really interested me was that the persons whom I had trained are now the teachers and training the next generation of students in therapeutic endoscopy, in laparoscopy, and proceeding on. They are innovating things that we are unable to comprehend as to where tomorrow the endoscopy will be in the armamentarium of a GI person. As Dr. Crow has said, he has gone through entire gamut of the recent advances that has taken place now. But what is next? I'm very eager to see if Nagi has anything up his sleeve to tell us what he would be dealing with in one particular aspect of therapeutic endoscopy of ERCP.
Yeah.
Yes, Suri.
So while Dr. Nageswar Reddy is joining, it seems from Dr. Crow's lecture that we'll be moving more and more towards endoluminal surgery.
Can I ask a question, Dr. Crow? You could unmute yourself, sir. There has been some excitement with transoral incisionless fundoplication with a device called Isofix. I think the brevity of time didn't give you to expand on that maybe, or is that purely notional right now, or is there some credibility to that initiative? We had Stretta in the past.
Right. There's credibility. I think that you have to look at the evolution of the device. Initially, it was a gastrogastric plication. And if you do a gastrogastric plication, you know that there's cardia above your fundoplication or plication. The latest iteration is a gastroesophageal plication. It's less of a fundoplication than a plication. The early data seems relatively compelling, but like many anti-reflux procedures, we need longer term and objective data. Quality of life scoring is not going to, quality of life scoring and PPI use are not the outcomes we need. We need pH probes and we need data at least 1 year or longer. So that doesn't exist yet, but from a technical standpoint, the current iteration is better than the previous ones.
Thank you. We had some early experience with endoscopic gastroplasty, and I see that's your go-to destination for people who are not ready for laparoscopic or robotic bariatric surgery. You had a 10 to 15% total body weight loss at about a year and more. Is this part of your regular bariatric discussion for low BMI people, or is it somebody who comes demanding it?
So I'll back off those a little bit. We offer the procedure, but it is a very small percentage of our patients. I have to tell you that in our experience here in the Middle East, the long-term durability or even the short-term durability at 12 months or so doesn't seem to be super durable. So I think this is ideal for patients that are low BMIs, probably 35 or less, that may not be eligible for surgery, low metabolic disease burden. And I think that there's going to be a not insignificant long-term weight regain after these procedures. So I think we just have to caution on this. There's a lot of enthusiasm around the world. I perform it, but in very highly select patients. Most of the people who come asking for it are not candidates.
Thank you. We have Dr. Nageshwar Reddy with us. Over to you, Dr. Kanagvela, Dr. Gopal.
Sir Krishnarao, sir, please.
Welcome, Nagi, to the
Thank you.
meeting. I just gave a small introduction about you to the listeners and who are participating in this webinar. I think I don't have to repeat it. So I'll pass it on to you to proceed with your lecture on ERCP 2021 and future.
Thank you very much, sir. First of all, I'd like to thank the Surgical Society, Sunil especially, for giving this opportunity.
Thank you, sir.
And also, it's a big honor to do this talk under the chairmanship of Professor Krishna Rao, because Dr. Krishna Rao was actually the true inspiration for me to take up ERCP. Maybe 40 years back, when one of my aunt had a CBD stone, I had taken her to Dr. Krishna Rao. He was actually one of the maybe one or two people in India doing ERCP. I was fascinated by the way he took out the CBD stone, and since then, of course, I've been in this area. So thank you very much, sir, and the honor to be doing this with your chairmanship. The first ERCPs were actually done by a surgeon, McCune, in 1968. He was in Washington. He was a surgical gastroenterologist who was attempting to do an ERCP. He reported the first series of 55 cases in Annals of Surgery. What happened at that time was scopes were not very good, the view was not very good. It took him almost 4 hours to do each case. And he, of course, was a very busy surgeon. He got disgusted and then stopped doing ERCP. But since then, the Japanese took over the ERCP, and it was a Japanese physician, Ito Ari, and others who actually further progressed, and then ERCP became a standard of care. In 1973, Maynard Claassen and Kawai did the first sphincterotomy removing CBD stones, and this actually heralded the therapeutic ERCP. And since then, of course, ERCP has become the standard of treatment of many pancreatico-biliary disease. Now, what do we expect further on from now here in 2021? The major advances in ERCP have occurred because of advances in techniques, technology, and of course, changing concepts that have occurred in this area. So what I'll do over the next maybe 20-25 minutes is to go over these changes that have occurred and how ERCP is revolutionizing the treatment of pancreatico-biliary disorders. But also the advance in other areas coming in this, and therefore, in certain areas, ERCP is actually receding. And let's look at this. But one of the most major advances that has occurred in ERCP, in my opinion, is our ability to prevent post-ERCP pancreatitis. Among all the complications that ERCP, which is the invasive procedure, has, the most dangerous has been pancreatitis. It used to occur in about 9 to 10% of patients. But in recent years, with the use of rectal indomethacin, prophylactic pancreatic stents, and IV hydration, we have managed to decrease the ERCP pancreatitis rates to about 2%, which is, I think, a significant advance because we can now do ERCP fairly safely when it's indicated in this group of patients. The other major advance that occurred in ERCP is our ability not to do it for unnecessary indications. For example, sphincteropoid dysfunction was a major indication in Western world for ERCP, where patients with biliary pain or type 3 type of SODs underwent ERCP. And following this, the incidence of pancreatitis used to be quite high. This landmark study in JAMA by Peter Cotton and his group showed very clearly that in patients with abdominal pain after cholecystectomy, the so-called SOD3 patients, ERCP should not be done because it produces more complications than actually solves the problem. And therefore, I think we've become wiser and we started choosing our patients carefully. So what's going to happen from next year onwards is, or next few years, is that indications for ERCP are going to become very strong, and we'll probably do a proper ERCP only when it's indicated. The other major advance that occurred in this area is advances in accessories. For example, we're starting to use more and more these self-expanding metal stents. They're replacing plastic stents. And we realize that in self-expanding metal stents, which are actually made of this nitinol material, the material is getting superior. So these stents are developing much higher radial force. They're expanding. We learn from our cardiologists to use them carefully. And also we know that these stents should not only have a strong radial force, but paradoxically, they must have a weak axial force. The longitudinal force should be very weak. Only then these stents will function well. So we're now having stents which have a strong gradient, weak axial force, and these are the ideal stents. So these stents are now slowly replacing plastic stents. For example, we used to now think that in patients with advanced obstructive malignant jaundice, you have to put plastic stents, and those who have a lifespan of more than 3 months, we put metal stents. But this has now been shown not to be true. In this very large Dutch study, we have seen that all patients, irrespective of the stage of malignancy, a self-expanding metal stents is more economical and better palliative treatment for these patients rather than putting plastic stents. Similarly, we have published a study in patients with benign biliary strictures, chronic pancreatitis, post-transplant situations, where we used to put multiple plastic stents. We no longer use it. We now use a completely covered self-expanding stent in this situation. This is better than multiple plastic stents. And therefore, what we have shown that even in benign strictures, a completely covered metal stent is better than multiple plastic stents. So what is happening is now the demise of plastic stents in the use of ERCP. As we go further on, we are going to get a new dawn of metal stents. Self-expanding metal stents, technology is improved, the variety available, especially in the Eastern countries now. They're manufacturing very, very different kinds of stents. And therefore, I think the future is going to be use of these stents in our patients. Another type of stents that are going to be used in future is so-called biodegradable stents. Now, the advantage of these biodegradable stents is once you put them in, either in the biliary tract like these stents or in the pancreatic tract like these stents will stay in place for 6 months or 8 months and then spontaneously get biodegraded. And therefore, you don't have to remove the stent. So, the more and more now these stents are going to be used. And this is an example of a benign biliary stricture in a patient who had a cholecystectomy done. What we are doing is to use this special biodegradable stent put across the place, and this stent goes in, and with the stent we can open up the biliary stricture. Once the stricture is completely open, we leave the stent in place for about 3 months, and after that the stent spontaneously dissolves. You can see how we're expanding the stricture with the stent and the balloon, and after 3 months this stent is dissolving spontaneously, so we don't have to remove it, and this patient does not have to come back for a checkup. So this is a major advance, and I think more and more these biodegradable stents are going to be used in ERCP for benign biliary strictures, in post-cholecystectomy leaks, and in patients who have to undergo neoadjuvant therapy before surgeries. Single procedure is sufficient. Similarly, in pancreatic benign ductal strictures, prophylaxis for pancreatic stents for ERCP, we can use this so you don't have to go in and take it out again. So a lot of indications are coming up, and I think over the next few years in ERCP, we're going to use more and more these biodegradable stents. The other major advance has occurred, and where we are moving towards is in endoscopic adjuvant therapy. For example, in a patient with a pancreatic or a cholangiocarcinoma who's advanced, whom surgery cannot be done, we should just put these stents and just leave them alone for palliation. They should live for 3 months, maybe 6 months. But we're now thinking further on. We're thinking, why not we put a stent and also give them adjuvant therapy, either with photodynamic therapy or radiofrequency ablation, and increase the lifespan. So what this does is that we can improve palliation, increase survival, increase stent patency, improve quality of life by one of these methods, photodynamic therapy or radiofrequency ablation, which are now doing routinely. The most dramatic results have come with photodynamic therapy, and these are results from Ortner's group in Germany, who showed that if you have a patient with advanced cholangiocarcinoma, you just put a stent, the patient lives for 98 days. But if you do a photodynamic therapy and then put a stent, this patient is living for 490 days. This is a dramatic difference. So also, we know that you can prolong survival by this technique, but unfortunately, photodynamic therapy has several disadvantages. You can have a severe photodermatitis. These patients cannot go out in sunlight and so on. So what is the alternative? The alternative is radiofrequency ablation, and now we are starting to use this more and more. This is from a Korean company, StarMed, where we use these catheters which can be passed in ERCP into the bile duct, and then we give radiofrequency ablation at a temperature of 75 degrees for 2 minutes, and then again, the efficacy is again quite dramatic. You can see a cholangiocarcinoma here. We can see a cholangioscopy picture, how thin this stricture is. After radiofrequency ablation, it opens up. And we have now shown that in these patients, not only do we increase survival, you can see the survival is markedly increased with radiofrequency ablation, but also the stent patency is increasing. And this probably decreases the incidence of cholangitis and again increasing survival. So therefore, in all patients with cholangiocarcinoma, where surgery cannot be done or cure cannot be given, we are now palliating these patients using self-expanding metal stents plus radiofrequency ablation. And we are now achieving survival rates which are reaching between 4 to 5 years in many of these patients. So you can really dramatically increase the survival in these patients with this. And this is, I think, going to increase further with a combination of radiofrequency ablation, of course, giving palliative chemotherapy plus stenting. So you see, palliation with ERCP now has taken a different terminology. In fact, we're talking about intermediate lifespan in these patients. So what is happening in 2021 and beyond? Plastic stents are being replaced by self-expanding metal stents, either uncovered or partially covered. And we're adding adjuvant therapy to these patients. Similarly, for benign biliary strictures, we used to use multiple plastic stents. We are now using a completely covered self-expanding stents, but we are moving towards a biodegradable stents. So the whole movement is towards something which is much more convenient for the patient and for the doctors. Now, coming to another area, difficult CBD stones. In a CBD stone like this, earlier, we used to go for surgery, but now using a combination of a balloon dilatation, that is, we do a sphincterotomy followed by a large balloon dilatation, and you can see even large number of stones or even large stones can be very easily removed using these techniques of a combination of sphincterotomy and balloon dilatation. So endoscopic post-sphincterotomy balloon dilatation has really revolutionized the treatment of CBD stones, and they are no longer difficult now. In fact, this is a meta-analysis which compared plain sphincterotomy versus sphincterotomy with balloon dilatation. You can see very clearly that for stones which are more than 1 centimeter in size, so-called large CBD stones, a combination of balloon dilatation with sphincterotomy can very safely remove all these stones without the need for mechanical lithotripsy. The other major advance that has occurred in this area is introduction of the so-called SPY scope or the single operator cholangioscopy, where you can insert the scope through the ERCP channel into the bile duct or pancreatic duct and then do a variety of procedures. So you decrease the radiation, you directly visualize the bile duct, you of course have better tissue access, and you can do directed therapy. And this is a study from Los Angeles published some time back, where they actually looked at large CBD stones and saw how cholangioscopy can improve your capability to improve these stones. And you can see in conventional and ERCP techniques, success rates with the large stones was only 2/3, whereas when you combine cholangioscopy laser, in majority, almost all these patients, these stones could be removed without the need for further surgery. So therefore, I think what is going to happen is more and more we are going to use this cholangioscopic technique of removing large CBD stones. So if we combine large balloon dilatation with cholangioscopy, then almost 100% of CBD stones can now be removed endoscopically without the need for surgical intervention. And this is happening in the area of pancreatic stones also. We can see this is large pancreatic stones. So we can actually put in a cholangioscope, and using a EHL probe, these stones can be completely fragmented. You can see a patient again, pancreas divisum is stone, a lot of mucin, and then there's a stricture there, and using again laser through the pancreaticoscope, we can do a stricturoplasty similar to what a surgical stricturoplasty is done. I think these are advances which are going to see further and further. These ducts can be opened up completely endoscopically, and then of course we traverse the whole duct. So the visualization of the biliary system is going to improve so much. So it's the cholangiocarcinoma. In fact, this is a stricture. Biopsies were negative, but once we use a cholangioscope, we can visualize this, and directed biopsies can be taken very easily. And this can make a dramatic difference. In fact, I'll show you 2 examples of 2 recent cases we have seen. Both the cases on ERCP showed strictures in the mid or higher part of the CBD, diagnosed as cholangiocarcinoma because other investigations were negative. But when we actually did a cholangiopancreatography in these cases, you can see in this case here, they turned out to be a mass. Biopsy from this mass showed it to be a lymphoma. Whereas the case on the right, you can see caseous material coming out of this. And of course, this showed an acid-fast bacilli, indicating this tuberculosis. And both of these cases responded to medical treatment without the need for surgical intervention, of course, significantly decreasing the morbidity in these patients. So these are the advances that occurred. And the other thing that's going to happen in future, this is a study we published recently in GI Endoscopy, where we took patients with indeterminate biliary strictures. So what happens is normally when you do ERCP and we look at these patients, the strictures is very difficult to say whether this is a cholangiocarcinoma or a benign stricture. So what we did is we took these patients, randomized them into two groups. One of them underwent standard ERCP brushings and biopsies like what you do conventionally. The other group, we immediately put in a cholangioscope and did cholangioscopic biopsies. And you can see very clearly in the so-called indeterminate biliary strictures, with an accuracy of almost 90%, we could make a diagnosis of a cholangiocarcinoma or a benign stricture when cholangioscopy is directly done. So therefore, more and more at ERCP, when we see a stricture where brushings and biopsies are likely to be negative, we do a direct cholangioscopy and take a directed biopsy. So therefore, the practice of ERCP is changing a little, becoming more aggressive towards actually visualizing the lesion under cholangioskopy and taking biopsies. Similarly, another area where we have dramatically improved our yield of therapies is in patients with chronic pancreatitis, pancreatic stones. We use a combination of extracorporeal shockwave lithotripsy, ERCP, and this is a recent publication of ours in pancreatology where we had 5,000 patients with chronic pancreatitis and stones using a combination of extracorporeal shockwave and ERCP. In about 90% of these patients, we could clear the stones, making them asymptomatic and then follow-up. The other area where we have new problems coming up now is in patients with altered anatomy. Many of the patients, especially in the Western world and now in India, are undergoing bariatric surgery. So when you do bariatric surgery and ruined by anastomosis, you cut off the stomach from continuity, and therefore doing an ERCP is very difficult in these patients. We can do an endoscopic assisted ERCP. These are often difficult. We can do lap assisted ERCP. You can see an example here where in the remaining stomach, we can make a small opening and go in with the ERCP scope along with our surgical colleagues. Or nowadays, we are doing US guided gastropexy. So what we would do is put a stent between these two stomach remnants, metal stents, go in through the endoscope and then do the ERCP, come back and close the openings again endoscopically. So all these are new advances. So as we go forward, beyond 2021, these are going to become common modalities that surgeons, that endoscopists are going to use to overcome these problems. One of the major issues that has occurred now in recent years is ERCP-related infections, the so-called carbamazine-resistant enterobacteriaceae. The CRE organisms have caused a major problem, and this was initially in Seattle from Dick Kozarek's unit, and then UCLA, there was a major report. This is because the ERCP scope as a complex tip is very difficult to clean it because bacteria can lodge here. And this CRE type of bacteria can cause severe infection and death. And this caught, I think, attention of this press, where the superbug was supposed to have caused infections and deaths. And therefore, it also caused the attention of our endoscopy colleagues, where we started trying to look at why this happens. And we found that at the tip of the ERCP scope is this O-ring, where the elevator is, and it's extremely difficult to clean this ring. And therefore, you can't really sterilize the scopes completely. So there's a problem here. So now the manufacturers are trying to get over it by using disposable scopes. So future ERCP scopes, and even now we started, all of our scopes now have so-called disposable tips. All the manufacturers having this so that we can eliminate this problem of infection. And we're starting to find that this is a good method. But what happened also was that FDA caught attention of this problem, and they're trying to move ERCP towards a completely disposable scopes. And you can see these are disposable scopes. The Exile scope is a single-use duodenoscope which is currently available. We have now started using it in our department. The problem is the cost. Fortunately for us, other companies are coming up, so the costs are going to go down. for the disposable scope, but this is the only way to ensure that you're going to do an infection-free ERCP. And these scopes, you can see the view is quite good. They are single use, and this is the first live demonstration that I had an opportunity to do at Orlando last year, where we used this disposable duodenoscope in a patient who had a very complex pancreatic-biliary obstruction. And you can see the view is quite good here. We could do a ERCP sphincterotomy, and immediately after the procedure, disposed of the scope. So you see, these disposable scopes are becoming a reality, and of course, we are going to use it only in certain indications because of the cost. We are still using reusable ERCP scope. We are modifying it to decrease the infection, but disposable scopes are going to come with limited use, especially in patients who are very sick, who have multiple infections, who have had transplantation done. You are careful about transmitting infection, or patients in intensive care unit where you can't transport your whole scope there. In these cases, we are starting to use these disposable scopes. But as the price of these scopes come down, their use is going to increase. And my prediction is by 2025, most of the ERCPs are going to be done by disposable scope, because the cost of the scope is going to come down to say $200 or less. And then it's going to be the standard of care in these patients. So sterile single-use endoscopes are going to come. But what is challenging the ERCP in general is more aggressive endoscopic ultrasound, which is taking over many functions of ERCP. And this is an example where there's endoscopic ultrasound drainage of the biliary tract can occur either from the stomach or from the duodenum. So this is more and more being used by endoscopic ultrasoundologists to drain malignant obstruction. There was this randomized control study which came from Florida group, Shyam Vardharaju and others, who actually started saying, why not we do primary drainage by endoscopic ultrasound rather than ERCP for patients with pancreatic cancer, and showed in this study that primary drainage of the biliary system was as effective on endoscopic ultrasound as with ERCP, with less complications. But I think the problem, of course, is that this is going to take time. Right now, ERCP is still going to be the main method of treating these patients. But there's several unanswered questions in ERCP, which over the next few years, we have to try and answer them. ERCP is a risky procedure. The volumes are dwindling. There are less randomized control trials because of less volume all over the world, and experts are coming down. So therefore, there are going to be questions asked of how we'll have to train our future endoscopists in proper ERCP, decreasing the risk, how to optimize our therapies with proper trials, and how to see that certain competency or skill level is maintained in ERCP. I think I'm glad that surgeons are increasingly taking up ERCP now. In our own unit, for example, Dr. G.V. Rao is a master in ERCP, and I'm hopeful more and more surgeons will take up, so that this division between physicians and surgeons would go, and ERCP would be a common procedure used for patients' benefit. Again, I'd like to thank Sunil and others for giving this opportunity, especially to give this talk under the chairmanship of Professor Krishna Rao. Thank you very much.
Thank you, Dr. Ageshwar, for taking us through the future. You've already been there many times and many factors and other aspects of endoscopy. And now in endoscopy, you have shown that things are going to change, and change for the better. And your concept of training the biliary tree into the stomach, transgastric, or through the duodenum, and again, to treat inoperable biliary malignancy with a radiotherapy is something that we surgeons should be aware of and follow it. Do you have any data that after your treatment of biliary malignancies with either the photodynamic or the radiotherapy, that they have become operable and undergone surgery?
Yes, sir. So this is a very good question. In fact, we have now treated over 200 cholangiocarcinomas with radiofrequency ablation. Most of the time, we are trying to increase the survival in these patients, and also increase palliation quality because the stent blockage rates is less and therefore they have less cholangitis. But in a few patients, especially those in the mid part of the CBD, after the radiofrequency ablation, when we're following up these patients following chemotherapy, we found a fairly dramatic reduction in the size of the tumor, and these patients could undergo Whipple's resection successfully. So this is, I think, going to be another future area where we can use this to downstage the tumor so they can undergo more radical surgery.
Have you used this? Have you used the same procedures in carcinoma head of the pancreas?
Yes, the problem with carcinoma head of the pancreas is that transductally we're not able to do it, but we can now do US-guided radiofrequency ablation, especially for neuroendocrine tumors. We're using it quite extensively, replacing surgery, because we can completely destroy the tumor of 2 centimeters in size, especially in high-risk patients and those who are symptomatic like insulinomas now. Routinely, we are doing radiofrequency ablation to ablate the tumor. These patients would not require surgery. In patients with carcinoma pancreas, we're doing it as a palliation, especially for pain which is very severe, can't be palliated by other methods. We're using this to radiofrequency ablate the pancreatic tumors.
Thank you. Would there any other members of the group have questions to? Yes, President.
Yeah, excellent lecture, Dr. Nagi sir, and many congratulations for so many accolades. Every time we meet, I see a long list of accolades added to your name, and we are all very happy for you. You showed one video of IPMN ablation. So is it a standard of care now, or it's coming up in a big way? What are your thoughts on that?
Coming up, but we still require more studies. We are now starting to use radiofrequency ablation for IPMS. Especially now, we are using it for cases where they're borderline for surgery, either they're not accepting surgery or they have some certain risk factors, and therefore we use this. And we're finding very encouraging results. So I believe that in a situation like IPMN, especially when it's not very malignant, borderline cases, there is a potential of completely ablating the mucosa using this technique, and we are starting to get some early results to suggest a 5-year survival rate which is significant. So I think this is something you should look forward to in future. Keep a watch in these patients. In fact, the first 2 series of cases were reported now in World Journal of Gastroenterology.
Thank you.
Yeah, Rangan will tell me.
Professor Reddy sir, it's been a wonderful talk and clear deliberation of the entire talk. Sir, I have a question, especially in post-Whipple's pancreatic leaks. How much ERCP helps, sir? I won't tell ERCP directly. How much an endotherapy helps, especially in case of pancreatico-gastrostomy leaks or a pancreatico-jejunostomy leaks? What is your experience on it?
So it is a difficult area because our access now to the papilla is gone. So you have 2 separate anastomosis, pancreatic and biliary duct. And very often reaching that area of anastomosis is not so easy, because with the scope we have to go through in a fairly long route. So in this type of situation, endoscopic therapy has a much lower role. We have sometimes, especially if it's not acute, immediate post-operative, some of these people, they come to us a little later with slightly dilated duct. In this type of situation, through endoscopic ultrasound, we have been able to cannulate the pancreatic duct, antegrade, and then go in and then do therapies. But success rate still is less than 50% in these cases.
Thank you, sir. The next question is, sir, it looks like from you, US is going to sort of technically challenge ERCP in future in accessing various ducts.
Yes.
Because the maneuverability looks very easier with the image guidance of ultrasound. Sir, how far we are in doing US guided ablation of pseudoaneurysms, or because it looks like endovascular access to the fine vessels, the gastroduodenal vessels or other things, it looks pretty easier with endoscopic ultrasound guided sclerosis.
Yeah.
Do you have experience on handling pseudoaneurysms and other vascular malformation with US guidance, sir?
I think that's a very good question again. Endovascular US is becoming a major subject now. We have some experience with the portal. For example, with the US, you can cannulate the portal vein quite easily. And nowadays, in some of the units, portal vein pressure measurements are becoming routine with the US. It is more accurate than doing HPVG, which we normally use to measure the portal pressure indirectly. This is a direct method. Of course, there are extreme units which have even done TIPS retrograde using US techniques. We have in our unit done quite a significant number of pseudoaneurysms trans-US because very easy to access. So through the US, we get to the pseudoaneurysm and inject glue or coils to completely block this area. So this has become, in fact, we reported a series recently using these techniques. Again, I think this is an evolving area, quite exciting. And because with endoscopic ultrasound, you get very close to the vessel and you can get very good delineation. Plus, now you have the capability of a Doppler. Doppler is integrated into US now. So you can actually put on the Doppler and see the blood flow. So you see the blood flow, inject glue or coils, and then again you see the blood flow which is stopped. The most important area where it has, in fact, taken over now becomes standard of care is patients with large gastric varices. Nowadays, instead of doing glue injection blindly through the endoscope, we are using US-guided injection, going to the feeder vessels, injecting glue and coil at the feeder vessel so that these gastric varices don't recur again. So this has become almost standard of care now. So I think endovascular US is another major specialty field that's coming.
Sir, how far we are away from getting a master endoscope, which has the US, which has the ERCP access. So if we have one single scope,
yes.
I think rather than having multiple scopes, how far is there any research happening on that side?
Yes. So again, because of confidentiality, I can't reveal exactly, but this is the area we're working with a company which has made a hybrid scope where you can actually do US, and when you come to an area of the papilla, you can actually turn the lens a little, it becomes a standard ERCP scope. So a combo scope, it's called a combo US ERCP scope is what they're working on, and that's going to become a reality, I think, at least in a year's time.
Yeah, excellent, Maggie. One more question. You are doing a lot of endoscopic treatment and ESWL treatment of chronic pancreatitis stones. So in your unit, do the patient go for surgery at all for chronic pancreatitis, or almost all the stones are removed endoscopically?
Now, again, this is a very good point. So what we did was, because the problem with the chronic pancreatitis, the therapy can be skewed. For example, if he goes to a surgeon, he'll get a surgery. If he goes to an endoscopy, he'll get endoscopy. It's like the barber chair phenomena. If you go and sit in a barber chair, you'll get a haircut, whatever. Even me, without hair, will get a haircut if you go to a barber chair. So it's called a barber chair phenomena. And this, to avoid this, what we did is we actually set up a pancreatic board with our unit. Every patient with chronic pancreatitis goes to the pancreatic board. And we have at least every week 10 or 12 cases. So they go to the pancreatic board, and the pancreatic board contains physicians, surgeons like G.V. Rao, and of course we have a pancreatologist. We have a clinical pancreatologist who does only clinical pancreatology. Dr. Roop Jyoti has come from Mayo. He doesn't do any procedure, so he's neutral. So we have endoscopists, GI, surgeons, and a clinical pancreatologist. All of us look at the images, and on imaging we decide. For example, if the patient has a single stone or small stones in the head region, dilated duct beyond, he would go for endoscopic therapy because we have 80% chance, especially with a powerful extracorporeal shockwave machine that we have. We know that is going to. If the patient has a head mass, pancreatic head mass, multiple strictures and stones, then he'll go immediately for surgery. There's no discussion at all. But there are in-between patients who have, for example, one stricture and some stone, or a patient who has multiple stones. In these patients, again, we've discussed, we tell the patient this can be done endoscopically, but surgery is preferable, or surgery high risk is there because you've got coronary arteries and so on. So we tell the patient and then give the choice to the patient. So giving this approach, we find that in fact we have shifted from endoscopic approach little more towards surgery, because surgeons would then, for example, a head mass, there's no point in doing endoscopic therapy. You had to go for surgery. Multiple strictures, no point in go for surgery. So we shifted towards, but even then, because ours is a reference center getting specifically reference, 70% of our patients would actually be relieved by endoscopic therapy, 30% would go for surgery. And I think using this pancreatic board, in fact, I strongly recommend for all units treating large number of chronic pancreatitis patients to have a board where a surgeon, physician, and a neutral person looking at it. And imaging will give you a very clear-cut decision on which patient to treat based upon what you find on, say, even a plain X-ray is sufficient very often to give an opinion. But an MRCP almost always decides what to do in these patients.
Yeah. Thank you, Nagi. We have Dr. Matthew Crow from Abu Dhabi Clinic, and I would invite him to ask a question or make a comment.
Yeah, outstanding lecture. I appreciate the opportunity to learn from you. I have a question in terms of the complexity of endoscopy now. So we have advanced endoscopy, which is now so many different buckets. But with the spectrum of procedures you describe with EUS and ERCP, is pancreatico-biliary advanced endoscopy different than intramural, different than luminal? And how do we address this in training? Are we going to be just one of these, or can anybody do them all?
I think, Matthew, that's a fantastic question, excellent question. In fact, that's what's bothering us also as we go. In fact, I was the president of World Endoscopy Organization, and we had several sessions addressing this. Endoscopy has become so complex now that it's difficult to be a pan-endoscopist, like what Krishna Rao was a pan-endoscopist, doing everything. Now we cannot do everything because we have pancreatico-biliary endoscopy, we have a third space endoscopy, and we have a regular luminal endoscopy. Plus, in addition, we have an advanced diagnostic imaging endoscopy. There are people like, for example, in Japan, doing only narrowband imaging or magnification endoscopy. And they're so good that they will spend 45 minutes as a single lesion, tell you everything about histology, infiltration, everything, because it's so good. So I think we are having these 3 or 4 buckets now. What I tell, in fact, our residents is that you can no longer be a therapeutic endoscopist like we were long back. We now have to decide when we get into endoscopy whether we want to be a third space endoscopist, a pancreatico-biliary endoscopist. They're totally different. So in our unit now, we are divided into 3 specialties. We have an youngster group of people doing only third space. They don't do pancreatico-biliary. There are people like me doing only pancreatico-biliary. We don't want to say, I want colonoscopies and all, don't want. Then there are people doing intraluminal endoscopy. So we divided completely. The future of endoscopy is going to be a subspecialization into these areas. And because endoscopy is a mechanical thing, you do large volumes, you get an expert in this. It doesn't require too much of intellectual things into this. So you become good with mechanical. So I think we have to subdivide ourselves and work in a specific area. And then this is a very important point you raised, Matthew. I think this is what going to the future.
Nagi, when do you think that endoscopists will replace all kinds of surgeons?
No, I think it's more than replacement. I think it's a cooperative. See, we are trying to give as much benefit to the patient as possible. And I think this term surgeons, physicians, endoscopy should be replaced, and all of us should be called minimally invasive therapists. Whatever, whether you're a surgeon or endoscopy, we are all minimally invasive. And we try and become minimally invasive so that the patient can get the same therapeutic benefit, is less invasive or less complicated procedure. So I think basically future is going to be, and again, this is what we're doing in our unit. It should not be physicians doing endoscopy or surgeons doing it. It should be together. Whoever has the skills, hand-eye coordination, should start doing. If you may be very good in laparoscopy, even a physician is very good, should continue. I think our basic training in gastroenterology has to be restructured, like what Peter Cotton say. You do 2 years of gastroenterology, and then you decide whether you want to become a minimally invasive laparoscopic person, minimally invasive flexible endoscopic person, or subdivide into pancreatico-biliary and so on. So I think the future, at least the patients are going to benefit if we're going to approach it that way.
Excellent, Nagi. Yes, sir.
Nageshwar, what is the role of a radiologist, therapeutic radiologist in your pancreatico-biliary?
Yeah, I think this is another very important area. In fact, we have a specialist interventional radiologist, pancreatico-biliary, because there are a lot of radiological interventions they're doing now. In fact, there are a lot of rendezvous procedures. We used to do all this complex type 4 hilar strictures, ERCP-wise, trying to put in multiple stents. We realize now the more simpler way is you combine with the radiologist, he puts in multiple wires, and endoscopically we take these wires and do a rendezvous. It becomes very easy, very safe for the patient. So there are a lot of procedures, and of course, there are bleeds which we can't control, they would control, especially small bowel bleeds and so on. So there's a lot of combined procedures. when I'm doing a very risky, say, ampulectomy, I always tell my radiologist, be around this, because if there's a massive bleed I can't control, immediately he'll go in and then control it. So I think there is a huge role, and I think all good interventional endoscopy units should also have a good interventional radiologist to help them out.
Yeah.
Okay, thank you.
Nagi, one question regarding endoscopic anastomosis between gallbladder and duodenum. I've seen
Yes.
some reports coming out. What are your thoughts?
So we're doing, I think this is a procedure which is sort of overdone a little by some enthusiastic endoscopists. The major indication is if you have a patient with advanced malignancy who also has cystic duct obstruction and a cholecystitis, then instead of doing a percutaneous or a surgical drainage, we can now very easily go in endoscopic ultrasound and then create a fistula between the antrum or duodenum and then put in one of these self-expanding metal stents, which are luminal opposing stents. So we do a lot of this, but only a specific indication in patients who have very advanced malignancy. In a patient who has a standard gallstone disease, there are some endoscopists who are trying to do this, create a fistula, go inside, remove the gallbladder stones and all. I'm somehow not for it, because I think the gallbladder is diseased in these cases, has to be removed. Optimum approach is a lap chole in these patients. So I think this is an important indication in patients with terminal malignancy having a gallbladder obstruction.
Thank you. Ishwar, you want to ask a question?
Thank you. Nagi, that was very excellent. Nice to hear you. Regarding, you said as we go 2021 beyond, there are going to be less and less volume of ERCP, less masters like you there may be. So what's the training? Are there any better models or better avenues there, like simulation or better simulation models where people can go? Because a lot of trainees are asking, as a surgeon, to cut down the learning curve. Is there any better way of teaching or learning?
Yeah. Again, Ishwar, that's a very important question, because that's what's bothering us. How do we train people better in ERCP? In fact, training in other modalities of endoscopy is not so difficult, because animal models and also even third space, we now have good animal models. But the problem with ERCP is the pancreatic biliary tract in most of the large animals, also pigs and dogs, is different from human beings. So it's not so easy to train exactly on animal. There are some simulators, we are working on that. The standard ERCP computer simulation is not still very good. There has to be work done on that. That's being improved. This is one of the areas. The second, of course, is that now we have good mechanical models. And for those who are interested in learning ERCP, I would strongly recommend the Guido Costa Magna model. Guido and his group IO together have made this very nice mechanical model which can be used for ERCP training, especially skills of cannulation. You can do sphincterotomy, stenting, stone removal, and so on. So we'll have to practice on these models initially. I think the era of going directly to the patient doing a scopy is no longer acceptable. So what we do in our unit is we actually have a graded method where they go through these mechanical models, then go through simulation, and then our gastroenterology PGs are told how to put in a side wing scope, remove stents and so on first. And once they get good at this, and then they're allowed to do selective cannulation, sphincterotomy and so on. But I think still it's a long process compared to other endoscope procedures, and we can only train a limited number of people to become good, because ERCP is, I think, more invasive than any other endoscopic procedure, especially pancreatitis and so on. And this can be quite disastrous to the patient.
Thank you. Thank you, Nagi.
Nagi,
Do you have any more questions, President?
I just wanted to compliment Nagi for the huge library they are having.
Yes.
And must compliment for the largest gastroenterological hospital in the world, IAGES. And because of the COVID pandemic, we have not been able to visit Hyderabad. Otherwise, it used to be the dictum to go to Hyderabad once a year to attend Nagi's workshop. Hopefully, maybe 2022, we may be able to attend in person.
We're planning, Sunil, in April 2022. Mid-April 2022, we'll have our next big workshop. So it's an invitation now itself for all of you. Should come.
Yeah. Thank you so much. And thank you so much for sparing your valuable time with us, and also Dr. Crow. I leave it to Dr. Kanagwal to take the program further.
And again, before we end, I just want to pay my respects to Dr. Krishna Rao. He is the one who can be called truly the father of ERCP in our country. He's the one who brought it, and then I also envy him that how he looks the same he was 40 years back and now. There's no difference.
Thank you, Nagi. I still remember you coming to the Wellington Hospital.
Yes, yes.
Me working in that narrow, small room and saying, if you can do that, I think I don't have to be in PGI or anything, and they can do it. And I think you have done exceedingly well in enlarging the scope of endoscopy in India and as well as in the world. Congratulations.
Thank you.
And thank you, Krishna Rao sir. Thank you, Nagi sir. With the permission of the president and the faculty, all good things have to come to an end. It's been a wonderful evening of learning from both legendary endotherapists. Thank you, Professor Rao, and thank you, Dr. Nagi sir. Thank you, Dr. Suviraj and Dr. Krishna Rao sir for moderating the session. Now we hand over the day's proceedings to Dr. Ishwar, our Dynamic Secretary of the IAGES. Over to you, sir.
Thank you, Kanagavel. Thank you, Professor Sunil Foregut, for an excellent presentation today, because today's presentation, both by Dr. Matthew Crow and Dr. Professor Nagi Reddy, I think they were so scintillating talk with so much of practice points, pearls of wisdom. I'm sure every surgeon will today onwards be, and already we all know IAGES has taken this training of surgeons in art and science of endoscopy to a larger extent through their regular fellowship training program, ERCP and Foregut advanced training program. And I just want to convey also to Dr. Nagi Reddy that we have been using the Costa Magna trainer in Trichy also with Govindraj, with the Krishna Rao direction. I think we found it very useful, even though the easy animal model people used. So I think the training on the surgeons is also equally important. I am really appreciative of you saying that it is not one-man job. Whoever is competent or the patient is right at the center, physician, surgeon, we all together with making the best possible care. I think I thank both the speakers for heartfelt appreciation from all the viewers across the globe. I'm sure thousands of people are coming on every alternate Wednesday 8:30 to watch our IAGES prime time. We made them proud, and our certificates of appreciation both to you will be arriving shortly in the email. Please accept our appreciations, sir. And of course, Suviraj, as usual, still, and also our my mentor and fatherly figure, Professor Krishna Rao, both gave a good moderation. Let all the practical points come out from our speakers today. And as a Central Office Under Secretary, I have a couple of pleasant things to update our viewers and also our members. As you all know, because of the COVID, we were not able to do the regular physical events, but still we are having the online fellowship courses of both the laparoscopy and the endoscopy happening in Medinet platform. People can go in, and also the advanced laparoscopy courses also with the 30 lectures are also there in oncology readily available for people to join. And the assessment will be in the subsequent on-site program or in 2022 February in Rajamundry, where we'll be doing it in GSL Medical College, doing our 19th annual conference. But in the meantime, in spite of the third wave on the doorstep, we are bracing ourselves to conduct and host two programs already pinned for this next month, the September 10th to 12th by Randeep Wadhawan in Delhi, in Falls, the advanced laparoscopy and upper GI. And also Dr. Kanagavel himself, along with the Ramachandra Medical College, they have taken the courage to host twin events, bonanza for all the delegates, both on the laparoscopy front, the FAGs, and also the endoscopy front, EFAGs. Both the programs are going to be happening. The chairman and all conveners of our surgical department, led by Professor Krishna Rao and our Zamir Basa, and all the people are coming there in person. I'm sure all of you will enjoy the delight of being in Chennai, and not only the academic and also gastronomic delight. I'm sure you will enjoy. And there are hundreds of people who have already done online program. Their assessment, if they want to do it before coming to the annual conference next year, they can choose the option of coming to Chennai during the final day on 24th to 26th is happening, the Sunday. And please contact Kanagavel how they can come, because they have done the theory part. They want to do the and the hands-on experience and also join in the live, they can do it very well without paying extra payment. But please contact Kanagvel regarding that. So we are all hoping to meet next year early, and with all of us vaccinated. In the meantime, and we are also, like I am sure Nagi with the whole AAG team is doing a lot of work in the COVID front. We are also as an academic organization with our social responsibility, have been doing something towards our citizens' welfare by means of what we call the COVID task force IAGES. We have collected close to 50 lakh rupees, and the latest 2 events happened in the last fortnight is donating 10 units of oxygen concentrator to all the hill stations where all that's really required, people even without cylinder. So it is because of this donations from USA, from AIMS India, there by doing the wonderful events. And also we are supplying 5 pediatric COVID ICU monitors also, because we are thinking the next wave may be affecting pediatric. So we are trying to be. So we have coined the term IAGES Sanjeevani, trying to save people and whatever little way we can do from the IAGES. So, but I'm sure with a positive mindset and with all of us encouraging our colleagues to get vaccinated, we have to look forward for better days. I'm sure with a positive note, I thank you all for having joined for another wonderful edition of IAGES Prime Time. Jai Hind. Thank you. Bye-bye.
Thank you.
Thank you, Ishwar.
everyone.
And before we take leave, I would like to invite both the faculties for Rajmundry IAGES 2022, our National Congress in February. And we'll send official invitation, but this is just an invitation in advance. We look forward to meeting you again in the scientific programs. Thank you so much.
Thank you.
Thank you, President. And with the permission, we call it a good evening to all of you. Thank you for joining us. Thank you, Docplexus. Thank you all the team behind us for making this flawless platform. We look forward for yet another exciting event in the coming fortnight. Good night, everyone. Bye-bye.
Thank you.
Excellent evening.